My name's Peter Godfrey-Faussett. I'm from UNAIDS, the science advisor at UNAIDS. I also have a position still at the London School of Hygiene and Tropical Medicine. Our next speaker will need very little introduction because Professor Audrey Pettifer not only is Kelly Kilburn's mentor, but she's also Professor of Epidemiology at UNC at Chapel Hill, and she's got a lot of experience on sexual behavior and HIV prevention, HIV testing. She led the HPTN-068 study, and she's really presenting on behalf of herself and Mary Stoner, who was meant to be here, but unfortunately was unable to travel to Paris at the last minute. So, Audrey, thank you for stepping in, and this is a further study relating to HPTN-068. Audrey.
Thank you. Great. Thank you. Good afternoon. So this afternoon I'm going to be presenting, again, luckily Kelly has presented, so you have a little bit of background already on the 068 trial, but looking at the association between school attendance and dropout and HIV and HSV2 risk in the cohort. I think this has already been said, but we know obviously that young women in South Africa are at a very high risk of HIV infection, and I think particularly that steep increase between the ages of 15 and 19 and 20 to 24 make it an area for important focus. So there's been a lot of debate over the years around the association between education and HIV, and certainly we've seen that in general in most countries in sub-Saharan Africa, that with more educational attainment we see a decrease in HIV prevalence. There's more emerging data on decreased incidence, and these associations tend to be strongest among young women. There also have been some studies that have seen a decline in genital herpes. So most of these studies have looked at what I've said, it's educational attainment. So how, asking someone when they're older, when they're out of school, how many years of school did you obtain? There's less data on attending school, so actually looking at the effect of being in school on the risk of HIV infection. And some of the major gaps in the literature to date, again, are that most have focused on attainment in adults. Most of the studies are cross-sectional. There aren't very many longitudinal studies to really get at sort of causality and temporality looking at attendance, and therefore the outcomes tend to be prevalent and not incident. So the objective of this analysis was to look at the effect of school attendance and dropout on incident HIV and HSV2, with the hypothesis being that those who attend less school and drop out will have a higher risk, who have less school and who drop out will have a higher risk. So again, Kelly indicated that this study was part of the 068 conditional cash transfer trial. And again, the study site is the Agincourt Demographic Surveillance Site run by Kathy Kahn and Steve Tolman in the northeastern part of South Africa, a very rural, high migration location with a high prevalence of HIV in the general population. So for this analysis, inclusion criteria included having to have at least 2 visits, and if you had prevalent infection at baseline, you were excluded. And school attendance, we collected this actually using the school rosters from the 27 high schools that were in the study, and we used a binary outcome, which was actually the conditionality outcome. So if you were over 80% attendance, 80% or over, you received the cash, and less than 80%. And dropout was indicating at any month that you had dropped out of school. And the outcomes were incident HIV and HSV2, and a number of confounders were examined as well. So this was a longitudinal analysis using both inverse probability of exposure weighted survival curves by attendance status, and also inverse probability weighted Cox models. So looking at the hazard ratio for dropout and attendance, and the origin of those models was the date of first negative test at enrollment, and censoring occurred either before a move, loss to follow-up, graduation, or the end of the study period, or the date of detection of infection. So just a little bit about who is this population at baseline. Almost a third had repeated a grade. So although they were all in school when we started the study, this is very common in South Africa to have repeated a grade. About 5% had an older partner. About a quarter reported ever having had sex, and so about 4% were HSV2 positive at baseline. 8% had ever had a child or been pregnant. 7% had already reported having dropped out at some point of school at baseline, and 5% at baseline reported that they attended school less than 80% of the time. Okay, so looking at results. So this is broken down into 1.5, 2.5, and 3.5 years of follow-up. And over on your left are the survival curves. So the solid line is low attendance, the dotted line is high attendance, and you'll see on going up on the y-axis, the risk of HIV and time and study years on the x-axis. And you can see that those lines diverge, basically showing the increase, the difference in risk. So if we go down to, let me see if this works. There we go. Go down to 3.5 years. So the risk of HIV acquisition in the low attendance group was 19.9%. And 7.6% in the high attendance group, leading to a risk difference of 12%. And you can see that, at the different follow-up time points that this risk difference increases for HIV. And that's just highlighting that. So, and then this is for genital herpes, and we see an even bigger, although the curves look closer together early on, when we get to the end, and that could be a bit of a data anomaly, but we have 38% risk in the low attendance group and 17% in the high attendance group, leading to a risk difference of 21% for genital herpes. This is looking at the hazard ratios for HIV and HSV2 for school attendance. So we see almost 3, both for HIV. So if you were in school, had low attendance, the hazard of infection was about 3, and for HSV2 to about 2.5. And for school dropout, very similar, both for HIV, the hazard being about 3, and for HSV2, 2.7. So in summary, attending school fewer days and school dropout were associated with risk of incident HIV and HSV2. And we think that interventions to increase the frequency of school attendance and prevent dropout should be promoted. I will say, as a little teaser, that Marie's been doing some work also on mediation, similar to Kelly's work, and actually finding that a lot of this protective effect is driven by sexual networks and sexual partners. So I think that this is really an important and exciting outcome. And I'd like to thank the HPTN and the funders, and also all of our study team as well. Thank you.
Thanks, Audrey. So this is open for questions, please. Come to a mic and introduce yourself if you'd like to ask a question. I can see we have one already, probably 2 already. Go ahead.
Thank you. Ariane van der Straten, RTI International. Thanks, Audrey, for a very, very nice presentation. And sorry if my question is a little naive, but I'm wondering if you had any information about what were the girls' way of filling their days, or what they were their activity when they were dropping out. Because is the protection to be busy all day with, in a structured environment, or is it that you are actually learning something at school? And so I don't know if you could tease that apart.
So this is part of Marie's dissertation, and so part of it was actually looking at associations between attendance and partners and numbers, and definitely girls who stayed in school had partners closer in age, had fewer partners compared to girls who dropped out, and that definitely seemed to be temporal, so that occurred before dropout, so they acquired these partners after dropout. And the mediation analysis really, I think, suggests that this is about networks, so being in a protected space, not so much about education. So we do not see any of these same protective effects for grade repetition. So girls who have repeated a grade and therefore are much older than they should be for age have partners similar in age, and also we just see a null effect on HIV and HSV2 for grade repetition. So, our conclusion for this data is that this is really being driven by, networks and protected space, and not about what you're learning, which I think jives with the school environment and the matric pass rates in this area as well. Thanks.
On the left.
Hi, Audrey. Thank you for that great presentation. I'm Sanyukta Mathur with Population Council, and we're finding similar studies in our work in Malawi, as well as observational studies that have been done in Uganda that show being in school is protective against HIV. And I was wondering if you had thoughts about, since school enrollment is very high, is it, are there policies then, or what is needed? Is it policies to get girls who dropped out back into school? In Uganda, I know universal primary and secondary schooling had a lot to do with that increase in school enrollment rate. So what's needed? And if I could ask a question for Kelly, for those where there was, you didn't see an impact on sexual violence, were you able to investigate some of the gender power dynamics of sexual and relationship power within those relationships? And is that really where, why there was sort of no effect of the CCTV, conditional cash transfer on the sexual violence? Thank you.
South Africa is known for having high secondary school enrollment, one of the highest, and so we did have had debates with people that an intervention like this may have a much greater effect in countries where secondary school enrollment is only 30 or 40%. So secondary school is free in South Africa, although there are other associated costs. This area, because it is so poor, the government actually deems, no secondary school fees, and then there's other things that kind of just make it easier for kids to go to school. There's very high social protection programs by the government in this area, which we think also contributed to high school enrollment. So I do think that those are policy level interventions that can help in countries by waiving secondary school fees. Thinking about feeding schemes in schools, uniforms are cited in many places as being a major barrier to attendance. So I think there are structural things that can be implemented to help keep girls in secondary school. I think it's more complicated when we talk about re-enrollment, and I'm not quite sure there, but I think at least so we don't lose them between the transition from primary to secondary, which is where like a big loss happens in many places. Yeah.
Should we just let Kelly give a very brief answer to the question about power, and then we'll have one last question?
Okay. I believe your question was if we investigated sexual relationship power for those girls who had sexual relationships. We looked through the sexual relationship power scale, and just for those girls who had had sexual relationships, and there was just no finding there. Similarly with the gender equitability men's scale, we didn't find any significant effect of the program on that scale. So we don't necessarily see that any of the girls had the program affected their empowerment in sexual relationships.
I would just say I do have questions about the SRPS as the best measure of what we're trying to get at, and I do think that's an area for further research as sort of better quantitative markers of what we're thinking of about empowerment in young women, because SRPS is a very common measure, and we just didn't, it's very high overall, there wasn't a lot of variability, and we just didn't see it associated with very many things, so,
Nuala?
Hi, Audrey. Thanks for a very nice presentation. I'm Nuala McGrath from the University of Southampton. My question is really about this population, is quite a mobile population within South Africa, and other studies have shown that. Your estimate of mobility or migration was 7%, I think. So were the population in your study like the rest of that age group in the area? Did they move between schools but stay within your study? Or?
Yeah, so I think in the school age, they were like on average 15 when they were enrolled, and they had to be in school. So I do think that they are different from girls who are not in school in that age group for sure, and I'm sure that they are lower risk than girls who are not in school. We're continuing to follow the cohort. We've had one post-study visit, and we're going back again next year, and already, once they leave school, the mobility just goes up. So, I mean, I can't exactly quantify right now, but over a third are in Joburg or in Nelspruit or other places. So I think that while they're still in high school, they're going to school, they tend to be, in the study area, and we can find them. Once they leave, then it takes a lot of tracing and a lot of follow-up to find them. But it is a rural home, so people do come back. They're, to the rural area for holidays. They're just not there all the time. Yeah.
Audrey, can I ask you one question just before, since we've still got half a minute to go? Okay. I mean, you skipped very quickly. I didn't really have time to see the confounders that you'd talked about. And I think that one of the things that always interests me with these sorts of studies is whether it's those, and I'm sorry to be I'm not being pejorative at all, but those sorts of girls who are going to catch HIV who drop out of school, or whether it's because they drop out of school they catch HIV. And I just wondered whether you'd really sort of felt that you could really address that. I mean, you're trying to. What do you think?
Yeah, I mean, I think it's bidirectional. I think it does happen both ways. Marie actually did a lag, so she delayed 2 time points to really try and get at this temporality of did this happen after dropout as opposed to before, particularly with like acquiring an older partner or having more partners. So we definitely it's increased the strength of the relationship when we lagged the time. So I think there is a very strong causal temporal relationship, but I think it also happens the other way. But again, for HIV, these are, incident infections, so I do think it's more likely they're dropping out, acquiring older partners in different networks, and then getting HIV.
Yeah, I wasn't really meaning just when you get HIV. I was meaning there was something inherent to you, quite apart from the schooling, as it were. It's the extent to which we say it's because you're in school that you don't get HIV, or rather it's
And some other characteristic.
other unacknowledged confounders that we haven't really addressed that lead you to get HIV, that also lead you to drop out of school.
It's possible. I mean, we did adjust for a lot, like socioeconomic status, orphan status, alcohol, drug use, other things that we might think be risky, and they did not, it didn't have an impact. But, that is something, trying to figure out who are the people dropping out and staying in is another thing that Marie's looking at. Yeah. Thanks.
Thanks very much.
Great. So our next speaker is Shona Dalal. Dr. Dalal is an epidemiologist and consultant working with the HIV department at the World Health Organization in Geneva. She led the work on HIV partner notification that resulted in the new WHO recommendation on assisted partner notification that was released in December 2016, and she'll be talking about partner notification services today. Dr. Dalal.
Thanks, Jason. Thank you. I'm happy to be here to be presenting on this on behalf of my other colleagues, and thank the organizers for recognizing the importance of this. So this is a photograph from the smallpox eradication campaign from the 1960s in Brazil. There were a couple of reasons why we were successfully able to eradicate smallpox many years ago, starting with having a vaccine, of course, but also surveillance and prevention. So mass vaccination campaigns achieved a lot, but cases still occurred. A revised approach that included surveillance coupled with contact tracing and ring vaccination of partners or of close contacts of people with smallpox is what led to final eradication. Fast forward to 2014, with the Ebola epidemic, again, surveillance coupled with prompt detection of new cases, contact tracing to identify transmission chains were critical to epidemic control. In STIs, partner notification is used for STIs to treat partners and to interrupt transmission chains again. In the world of TB, contact tracing of close and household contacts is a standard approach that's used for patients with pulmonary TB, TB HIV patients, children, and those with multiple drug-resistant or XDR TB. So clearly, contact tracing, partner notification works. How have we been doing with HIV? It turns out not so well. Although we know that the sexual and drug-injecting partners of people with HIV have a higher probability of also having HIV, partner notification is uncommon. We found in a global review that 67 countries had some approach for partner notification, but very few were actually implementing it. And although a lot of HIV testing occurs, the question is it focused on the right people? So this led to our current work. So we define partner notification or contact tracing as a voluntary process where a trained provider asks people diagnosed with HIV about their sexual partners and or drug-injecting partners, and then, if the client agrees, offers these partners HIV testing services. It can be offered in two ways: passive or patient referral, where the HIV client contacts their partners themselves, or assisted approaches, where a health provider assists with contacting their partners. And there are a couple of ways one could do this. In provider referral, the provider contacts partners directly. In contract referral, clients enter into a contract with the provider, this can be verbal or written, to refer their own partners for HIV testing within a certain period of time. If those partners don't come in for testing, the provider then contacts the partners and offers them testing. In dual referral, providers accompany HIV-positive clients when they disclose their status and then offers testing to their partners. So we conducted a systematic review on HIV partner notification to assess their effectiveness. We searched 5 electronic databases until the 1st of June 2016 and included studies which compared passive approaches to assisted approaches. They should have measured one or more of the outcomes listed below and should have been published in a peer-reviewed journal or a conference abstract. We found 10 studies to include that met our inclusion criteria. 3 of them were randomized trials, 1 was a cluster randomized trials, and there were 6 observational studies that included a control group. They covered a number of countries, and the studies most recent and largest were in sub-Saharan Africa. There were a number of different populations, including women, key populations, pregnant women, and people attending either STI clinics, VCT centers, or other inpatient facilities. What we found was there was a wide range of the partner test uptake, both in the passive and assisted groups, but there was a dramatic increase in the assisted groups compared to passive notification. So you'll see in both the randomized trials and the observational studies, it ranged from 3 to 52% in the randomized trials, but in the assisted groups, 51 to 74% of partners accepted testing. And focusing then on the proportion who test positive, this was universally high across most of the approaches, though slightly higher with assisted groups, but a very, very high yield approach for reaching people who are also HIV positive. This is a slide of a meta-analysis of HIV test uptake among partners of index cases using just the randomized trial data. And you could just focus on the top panel or the boxes in red. And regardless of how we identified a denominator of partner, whether it was all the partners identified in the top panel or the rate of partner test and return per index patient in the bottom panel, 1.5-fold to 2-fold higher rates of partners tested for HIV using assisted approaches than they did for passive approaches. Similarly, the proportion of partners who were diagnosed HIV positive was 1.5 times higher with assisted approaches than with passive approaches. Linkage to care, only 2 trials reported linkage to care data, and they found that 3.5-fold higher rate of linkage to care with assisted approaches as compared to passive partner notification. Very few adverse events occurred in either the randomized trials or the observational studies. These were measured either with intimate partner violence, abandonment, or other social harm. And as you can see here, because of the few events, the confidence intervals are very wide, but there was not a difference between assisted approaches and passive approaches in adverse events. However, of course, we say that the potential for harm should be discussed with HIV-positive clients before partner notification occurs. These results will be published shortly in AIDS, I should say. 2 randomized trials from Malawi found that the difference between passive and assisted approaches differed as time progressed. The red dotted vertical line indicates about a 7-day period after a diagnosis, a positive diagnosis. And you can see that it may not be visible, but the lower line is the passive approaches and the others were the assisted approaches. And so this indicates that people who do not inform their partners within a week or so of being diagnosed HIV positive may be less likely to do so in the future going forward. And so the timing of partner notification and when it's provided may be important. This is a slide that describes an assisted partner notification case of a young woman in Kenya who engaged in transactional sex. In the larger circle on your left, she forms the center of the circle, and using partner notification, they identified 8 partners of hers, 4 of whom were HIV positive, as identified in the purple figures. And following them through partner notification, and additional people were identified as being HIV positive. So from one index case, 9 additional people were identified as being HIV positive. Now, following the dotted line to the right, there was a friend of this person's who also engaged in transactional sex, and through that process, another 5 HIV positive persons were identified. So really what this illustrates is the increasing number of people who can be identified as being HIV positive through a partner notification approach. These results led to our new WHO recommendation that we released in December last year, stating that voluntary assisted partner notification services should be offered as part of a comprehensive package of testing and care to people with HIV. Our study had some limitations. We only found 4 randomized trials with which to do meta-analyses, but the results were very consistently favoring assisted approaches. Statistical heterogeneity occurred for some outcomes, although our sensitivity analyses using different denominators for partners and methods of outcome measurement found consistent results. The pooled synthesis on harm indicated very few events, and because of that, the quality of our evidence was downgraded due to the imprecision and the large confidence intervals and the risk of bias. However, looking at similarly few adverse events from observational data suggests that the rate of harm is unlikely to differ between assisted and passive notification approaches. So in conclusion, assisted partner notification is an effective means of reaching people with undiagnosed HIV. It increased HIV test uptake among partners. High proportions of HIV-positive people were diagnosed. It increased linkage to care among partners with very few reports of harm. Voluntariness, confidentiality, and choice are critical. Partner notification should be offered periodically as people's situations, their partners, and their willingness to engage in partner notification may change over time. Laws and policies that stigmatize, criminalize, or discriminate against key populations or people with HIV can make partner notification challenging. In our global policy review, we found 21 countries with some form of mandatory notification. Mandatory notification is never justified. We don't support that in any form, and people should be offered choice and the benefits and risks of partner notification so that they can make informed decisions for themselves. So moving forward, we're good about thinking about the person who tests positive, who's in front of us, the client, and we have concern for their health and well-being in order to ensure that they access treatment. I invite you to consider the people who are going about their daily lives but don't have an idea that they have been exposed to HIV. Their health and well-being is also important. And as we think about how to reach the first 90 and the 30% of people who have undiagnosed HIV globally, to consider HIV partner notification. Assisted partner notification is a high-yield public health approach that works. It may not be novel, it is not sexy, but it is effective. And we hope that with the release of our guidance on partner notification, that countries and programs will incorporate it into their HIV testing services routinely so that they can focus those testing services where it will have the greatest impact. Thank you.
Thank you, Shona. Yes, Tim.
Great. Great. Thank you very much. Tim Mastro with FHI 360. Shona, really good job. It's wonderful to see an evidence base being applied to what is likely a very effective intervention. But there remains tremendous resistance, as you know, in many communities, especially in generalized epidemics, to some form of partner notification services. Given your information, were you able to glean any insight into I would imagine context is going to be very important in this versus urban settings, peri-urban, small towns, or rural. Did you get any insight into, will this work in a village somewhere, or does it have to be done in a more urban setting?
So the studies that we looked at came from a range of different types of facilities. Some of them were in rural settings. Some of them were with key populations in the United States. And across the board, the results were very clear on uptake, on the proportions diagnosed, and on very few reports of harm. So I think with sufficient training of providers, ensuring that they understand and provide people different choices of approaches, people might have choose one approach for one partner, say a casual partner, and a different approach for a close or long-term partner. It appears to work across the board from these few studies that we did look at.
Keep up the work.
Thank you.
Yes.
Hi, Ariane van der Straten again. Thanks for the nice presentation. Linked to Tim's question, did you do any, or are anybody doing any cost-benefit analysis to see at what point in the epidemic is it sort of cost beneficial to try to trace and contact people versus it's so generalized that you should just do a blanket approach to, attract everyone to test for HIV. So have you looked at different approaches given the level of the epidemic in a setting?
Thanks, that's a good question. So in terms of cost, there have been some studies that have looked at cost, and a couple of points to make there is that first, when you look at, if you were to look at the cost per case detected, because it's a very high yield approach, it does show to be cost effective. And as Dr. Shannon Hayter presented 2 days ago in Zimbabwe, they found that because of the high proportion positive, it was as cost-effective as PITC in a facility. So we would suggest that in a generalized epidemic or anywhere, once someone tests HIV positive, the probability of their partners also being positive is very high and is a worthwhile approach. Of course, it is an intensive intervention, and so the costs are higher than, say, just giving a person a card. So the costs, there's a very wide range of costs depending on country and context, and it ranges from passive referral approaches that are less than $10 to up to $30 or $40 per case identified for assisted approaches. But when you look at the cost per case identified, it is very cost effective.
Okay, in the interest of keeping us on time, we're going to move to the next speaker, but those of you that have questions, I'm sorry, if you could hold them, and if we have time at the end, we'll come back around to you.
In which case, let's move swiftly on to Carlos Toledo. Dr. Toledo joined CDC in 2002 and has moved to South Africa, where he was the chief of the HIV prevention branch at CDC South Africa. He's now back in Atlanta, where he runs the voluntary medical male circumcision team. And Carlos, the floor is yours. Thanks.
Oh dear, and my technological...
Click on it again.
Geez. Whoops. Oh, there we go. All right. Wait, is that it? There we go. Perfect. Good afternoon, everybody. Thank you so much for joining us to not hear about PrEP and representing the good old medical male circumcision, forgotten intervention. But I wanted to acknowledge my co-authors, many of which are here actually today and would be more than willing to answer all of your difficult questions. So what I will be presenting is on the association between male circumcision and STIs and HIV among women in Ngunguluvu district of South Africa. And you can only ask a question if you can say the name of that district correctly. All right, I think everybody knows this, but just as background, medical male circumcision provides a partial protection to men from acquiring HIV through heterosexual sex. It has been dramatically scaled up over the last almost 10 years, including in the area where this study was conducted. And to date, we've, as you know, worldwide, we've conducted over 12 million circumcisions. And the early studies and observational data showed that MC also partially protects men's female partners from acquiring HIV and STIs. And this may be done through an indirect protection by lowering the prevalence in the population. However, there's really been a lack of data at the population level, especially since the scale-up of MC has occurred. And that's one of the contributions we believe this study makes. So this study is part of a large project called the HIV Incidence Provincial Surveillance System, or HIPS. I do remember having a contest to name this, and we like the name HIPS. It's done in the Greater Edendale and Vulindlela district areas of South Africa, which is a really high HIV prevalence and STI area. And baseline data collection included questions regarding the circumcision status of women's recent sexual partners, as well as testing for STIs. Data collection occurred in 2014 and 2015. It enrolled almost 10,000. This was the baseline data. It enrolled almost 10,000 participants, and the HIV prevalence was over 36%. This just shows enrollment in the baseline from the 15,000, over 15,000 households that were sampled. 9,812 individuals were enrolled and analyzed with laboratory data. Of these, 64% were women, and of these, 76% are included in this analysis, which is over 4,700 women. The next couple of slides are actually going to give you a little bit of background on the male circumcision prevalence in this area, although this is not the main presentation, because for this presentation we're looking at the association in women. We wanted to give this as a background, that as you see in the overall population, in this population there's about 32% prevalence of male circumcision, with younger men having a much higher prevalence of circumcision. Only about 10% of men reported having traditional circumcision, which is similar to this area where traditional circumcision is not widely practiced. This data, again, we're looking at men, shows you the STIs outcomes based on circumcision status, and you see that circumcised men had significantly lower prevalence of most STIs, including HIV, where circumcised men in this sample had 14% HIV prevalence, while uncircumcised men had 34%. Okay, so let's go back to the analysis looking at women. So there were structured questionnaires that were administered by trained staff and self-collection of biologic samples. And the self-reported data on demographic and risk, and importantly, women were asked about the circumcision status of their three most recent partners. There were biologic samples that included, as you can see there, vaginal swabs, serology, and plasma. For this analysis specifically, we looked at female participants with at least one lifetime male sexual partner with a known circumcision status. And women were then grouped by circumcision status of the most recent partner, and we conducted descriptive and univariable analysis and multivariable logistic regression, where we created individual models for each STI using predictable variables with univariable associations that were significant, plus partner circumcision. And the models that we'll show are displayed with and without the inclusion of HIV and other STI infection as predictors, just due to the complex relationships between STIs and HIV. So in descriptive analysis, you see here that 35% of the women reported having a circumcised most recent partner, while the rest reported an uncircumcised partner. And this is similar to the data that I showed earlier about the prevalence of circumcision in this population. Women with circumcised most recent partners were significantly younger, had lower incomes, larger households, more education, and fewer pregnancies, and slightly total number of partners, and a lower HIV prevalence, as you can see there at the bottom, 41% versus 54%. In univariable analyses, these looking at the women under the age of 25, you see that circumcision of the most recent male partner was protective against HIV and HSV2, but was associated with higher prevalence of self-reported history of any STI. In univariable analysis, now looking at women over the age of 25, you see that circumcision of the most recent male partner was protective against syphilis, as well as any STI other than HIV, primarily driven by HSV2 here. However, it was also associated, like the younger women, with higher prevalence of self-reported history of any STI. In multivariable analysis, having a circumcised male most recent partner had a protective association with HIV and HSV2. Interaction terms were not significant, including interaction with age. So, in conclusion, our descriptive analysis shows that 35% of the women reported having a circumcised most recent partner and significantly lower HIV prevalence. And our univariable analysis, MC of most recent male partner, had a protective association with HIV for younger women, which is important for the programs that we're launching to protect young women. HSV2 for both groups, as well as syphilis for older women. And in multivariable analysis, MC was protective with HIV and HSV2. So women whose most recent male partner was circumcised had about 30% lower likelihood of having HIV and 20% lower likelihood of having HSV2. So this is consistent with the observational and trial literature and support that there is community-level protection against HIV and some STIs among women based on circumcision status. So a few limitations that I want to note. First is, as I mentioned, about 12% of men reported having been traditionally circumcised, and female partners may have reported these as circumcisions, and for many reasons, including issues of potentially not being complete circumcisions. It's important to note that. The circumcision status we recognize of the most recent partners does not capture the full exposure history, and this is something that we in the HIPS group are looking at, because we do have data that will be able to capture, or that captures more of an exposure history of women. And VMMC is a package of services that includes circumcision, but it also includes screening and treatment for STIs and referrals to treatment, which would decrease the male infectiousness and may contribute to the associations that we're seeing. So just in closing, the scale-up of VMMC throughout sub-Saharan Africa has been impressive or historic, with over 12 million circumcisions, and it's obvious that it's not only having an impact on men, but also on women's health. And this is in the context of an area where prevalence was only 32% at baseline. So if we are to think about the way that we are trying to scale up circumcision to 80% at least in the 15 to 29 or 10 to 29-year-olds, we would imagine that this would be even greater. Comparisons with associations in men may allow us to determine better this idea of this, whether this is a direct or indirect effect, and it's something that we will be looking in the HIPS data, because we do have much more information in our follow-up cohorts. As mentioned earlier, higher self-reported STI history prevalence among women with circumcised partners. This was a finding that we think may be due to differential ascertainment, because VMMC typically involves STI screening, which could potentially lead to disclosure to partners. And then there's obvious broader operational synergies between VMMC programs to improve, and those that improve women's health. It's, I know, something that we haven't necessarily in the VMMC world probably maximized, but programs like DREAMS and things like that are starting to really think about the role that MC in the community could actually have a great impact on women as well as men. So I'd like to acknowledge HIPS is a very, very large study with many, many players, but I would like to acknowledge everybody who works on it, including the district and the local health departments that have been incredibly supportive of this project. Thank you.
Thanks, Carlos. It's always great to see these big population studies are really beginning to contribute some additional understanding of what goes on in HIV. Let's have a question.
Thanks. Ginny Schubert, New York City. I was just wondering, were you able to control for engagement in care? Because obviously if someone is virally suppressed, they cannot transmit. And so regardless of circumcision.
Yeah.
And if the folks that had circumcision were more likely to be engaged in care of any kind, then they would also be more likely to be.
That's a good point. So, and I should have probably given some context of ART coverage at this point in time, but ART coverage was actually fairly low at this time in South Africa. Yeah, but it's a great point.
Hi, Anna Herb from 3IE, International Initiative for Impact Evaluation. So there seems to be a possible correlation between male circumcision and awareness of prevention, and I was wondering if you controlled for condom use in your analysis, and maybe you mentioned it and I just didn't see it, whether that would also contribute if the partners that are circumcised are more cautious about their sexual behavior.
Yeah, I don't think we controlled for it. We'd have to look to see how much there is in this data set regarding, I mean, we obviously collected a lot about exposure to different prevention interventions, and we can look at condom, but yeah, no, that's a great point. Thank you. Or even just other prevention interventions that were present.
And Carlos, perhaps a little, in a way, related, I wondered whether you'd got data on ethnicity and tribe, or how homogenous things were in terms of sort of cultural practices relating to circumcision and sex.
No, that's a great point, and this is a predominantly Zulu area. I don't remember exactly what the percentage, but it's predominantly Zulu. That's why you see the traditional circumcision being very, very low. Yeah. All right, thank you, everybody.
Thanks very much. We'll keep time for the end, if possible, for the other questions for Helen is a Professor of Infectious Diseases at the London School of Hygiene and Tropical Medicine. She's also Director of Research at the Zambop Project in Lusaka, where she's lived for the past almost 20 years. She runs, well, I better not say, actually, I can see Richard Hayes in the audience, so I better not say she runs the pop art study. She is a co-principal investigator of the very large pop art study and runs the Zambian part of that. And Helen's going to talk to us, please.
So thank you very much. Yes, I'm going to talk today about increasing knowledge of HIV status amongst men using oral self-testing on behalf of a large number of investigators. I'd just like to say that this sub-study was funded by the International Initiative for Impact Evaluation, 3IE, and the self-test kits were provided by the UNITAID PSI STAR initiative, but the main HPTN 071 study, the funders as well, are acknowledged here. So HPTN 071, or the pop art trial, is a very large cluster randomized trial in 21 urban communities in Zambia and South Africa, investigating whether a combination HIV prevention package, which includes universal HIV testing and treatment, can reduce HIV incidence at community level. Now, this trial has been very successful so far in attaining the first 90 in these urban populations, but we know that we have testing gaps. And if you look at the two graphs I show, those are data from the second year of the intervention. The black line is the start of the second year, and the blue line is where we'd got to by the end of the second year of the intervention. And you can see for women in the top graph, we have reached the first 90 in all but the youngest age groups, which are the 15 to 19-year-olds. But for men, we failed to reach our target across a wide number of age groups. And so we wanted to try and see if we could address these gaps. So we decided to pilot offering oral HIV self-testing as a choice, as an option, along with our regular HIV testing services. So this sub-study was a two-arm cluster randomized trial, with the unit of randomization being the zone of a community where a pair of lay counsellors, we call them community HIV providers or CHIPs, and I'll refer to them as CHIPs throughout the rest of the talk, they work. Our primary outcome was the proportion of all adolescents and adults living in those areas who knew their HIV status. And by knowing HIV status, I mean either knowing that you're HIV positive and declaring that, or actually testing with the CHIPs. We had predefined subgroup analyses by sex and by different age groups and characteristics. We chose 4 of the HPTN 071 intervention communities in Zambia for this sub-study, and these had a total of 66 CHIP zones, which were randomized, either to continue with the standard pop art intervention, or to include the intervention of the offer of an oral HIV self-test. And you can see how the randomization worked out, with the blue areas being the intervention zones of these communities and the white being the standard of care. So just to run over what the standard of care was, the standard of care was the intensive pop art intervention, which includes a door-to-door household-level offer of universal testing, so that's testing everybody, using finger prick rapid diagnostic tests. Anybody found to be HIV positive is referred to immediate antiretroviral treatment. The CHIPs also screen for TB and STIs. They refer for voluntary medical male circumcision, and also provide condoms and other referral services. And they do continuous visits to the household for retention and adherence support. So that was our standard of care for this sub-study. And in the intervention arm, what we did was we included the option of oral HIV self-testing using the OraQuick test. And this could be done when the chip was present, which we call supervised, in the absence of the chip, which we call unsupervised, or individuals could take the test kit for their partner and give the test kit to their partner, which we call secondary distribution. So we conducted this sub-study between the 1st of February 2017 and the 30th of April 2017, and these are the two arms. In the standard of care arm, we enumerated 13,706 people, and in the HIV self-test arm, 13,267 individuals. And you can see that largely the two arms were similar. This is the flow chart. I know it looks a little bit daunting, but I'll talk you through it. So if we start on the left in the control arm, we enumerated 13,706 individuals, of whom the chips never saw 22% who they were absent, and 1.7% refused to take part in the intervention. So of the 10,456 individuals who were seen, about 11% had a known HIV positive status, leaving 89% eligible for HIV testing. 84% of these individuals took up the test using the finger prick rapid diagnostic test. In the intervention arm, we had 13,267 individuals, of whom 21% were absent and 1.5% refused participation. So of the 9,967 individuals who were seen, 9.5% had a known HIV positive status, leaving about 90% eligible for testing. And 86% of these accepted the testing, and you can see that 55% chose to use the oral self-test and 45% chose the finger prick rapid diagnostic test. You can also see that in the two arms, the percentage diagnosed as HIV positive using the rapid diagnostic testing was the same at 2.5%. Of those who chose the oral self-testing, 88% chose to do this in the presence of the chip, and only 12% chose to do this in the absence of the chip. 323 people who were not initially seen also tested via the secondary distribution method, that their partner collected a test kit on their behalf, and 75 of these, the results were returned again through that partner, and 25% were then seen in person by the chip. And you can see that the yield of these different methods for the supervised testing, it was very similar to those who used the rapid finger prick testing, but then with an increasing yield as we go across the graph. So what are the results? So if we look overall, we see an increase of just under 3 percentage points, which gives an adjusted odds ratio of 1.3, and the confidence interval does not include 1. There was significant effect modification by sex, and so for men, we see a 5 percentage point increase in knowledge of status, which again is statistically significant, but there was no difference for women. For young adults, aged 16 to 29, we again see a 3 percentage point increase in knowledge of HIV status, which again is statistically significant. We also looked at those individuals who had been resident in those same zones in the previous 2 years of the intervention but had never tested. And in that group, we saw a 9 percentage point increase in uptake and knowledge of HIV status, which again was statistically significant. We also did qualitative work in these communities, which really showed that HIV self-testing was very acceptable for a wide range of people, and that individuals liked it, they felt it empowered them, and it enhanced their confidentiality. So, in summary, HIV self-testing increased the knowledge of HIV status amongst the general population, but really amongst men, younger adults, and those previously not tested. Now, the absolute effects of this may be modest, but remember, this is a highly tested population. These individuals have had 3 years of intensive intervention offering them repeated HIV finger prick testing in their own homes. And so we're really talking about the hardest to reach populations here, the highest hanging fruit. And so I think even though the effects are modest, it does show a benefit for using oral HIV self-testing. The self-testing was acceptable and it was safe. We had few social harms were reported and most were within discordant couples. The secondary distribution was also feasible. It led to increased couple testing. So what are the policy implications of this? Well, I think we feel that HIV self-testing is a potential solution to reach the hardest to reach groups. And it may also be very attractive for middle income and working individuals. We did see a difference by community with one of our more affluent communities really liking this method much more than the others. It can enhance couple testing. And in addition, it can also help to overcome barriers due to fear of finger prick, which we do know some people really don't like the finger prick testing. It can increase privacy and reduce experience stigma, although it may not challenge stigma related to HIV testing. And it can reach men who are not found at home via secondary distribution. So I'd like to thank all the research participants and their families and the research communities, as well as our community advisory boards, all of our study staff. Thank you very much.
Thanks very much. So we've had partner notification and now self-testing, both in the new WHO guidance on HIV testing services. I can see a question on the side here on the left, my left. Go ahead.
Thank you. I'm Tejani from Lesotho. I've been listening to a couple of preventative measures that can be put on place. And in most of the presentations that were given, this is a question to the panel. It appears to me that one man possibly can infect 4 women. And it says to me, if one man gets infected, there's a high chance that another 4 women will get infected. So my question is, as a summary, what is it that we can do that will keep men or young women, young men to stay negative? That is the question.
So I think we'll let Helen just make a couple of general comments about that rather than have the whole panel so that she can get the answers. And then if we have time at the end, the other panelists can make some additional comments. Helen, do you want to talk at all about the...
So obviously we've got voluntary male medical circumcision, which is vital for young men, and we're seeing increasing rollout of that across many countries. But I also think we need to be treating men and finding men for their own benefit. I have a bit of a bee in my bonnet about this. We see that men have worse outcomes when they're HIV positive because they're not getting diagnosed early enough, they're not virally suppressing, and they're having higher mortality rates. So I think we need to really focus our efforts at finding everybody who's HIV positive. We need to look at different models that appeal to different segments of our populations and really work for everybody rather than just focusing on the easy to reach, which is often the women.
Let's have another question. And perhaps we'll take the questions and then let you answer in the end, Helen. So if we go 1, 2, 3, 4, quite quickly, please.
Yes, thank you. If you could speak a bit about the follow-up then, once these individuals self-tested, and then how were those results then identified, and then what happened after that? Thank you.
And from the middle microphone, just can you remember these, Helen? I'll make a note as well.
Yeah. I'm Charles Namisi from Makerere University, Uganda. I'm more interested in the qualitative, because you are talking of the policy implication, and the quantitative will never give the politicians what to do. So I want to follow up the why were they not testing, and those who tested, what were the experiences? Because you just came to pick just a quote, and that leaves behind a lot of things, because I thought you would show at least some deeper analysis that has rigor and that's credible, that then you can add up to explain the number. Thank you.
Thank you. I expect Mitzi wants a qualitative question as well. Mitzi?
Mitzi Gaffos from Strive at the London School. So I was interested to see that although you had high uptake of the self-test, only 12% was unsupervised. And that surprised me, and I wondered whether you had any insights into the reason for that. Was it just an issue around concerns about the needle? And what did people understand about the accuracy of the 2 options of the tests? Thank you.
And the final question?
Defla Marange from IRD in France. Just a question regarding how did you manage to get the result of HIV tests in case of secondary distribution, as it could be a challenge in the field? Thank you.
Yeah. Okay, so I think that's fairly similar to the sort of linkages and follow-up. So we did ask for, in our setting, if the chips were there for the supervised testing, obviously they asked to get the results there and if people would share them with them, and most people did. I mean, our chips have been in these communities for a long time and are very well known. For those people who tested unsupervised and when we left testing kits for secondary distribution, the chip made follow-up visits after a week and then continued following up until they found them. We asked for all test kits to be returned to us, used or unused, because we did distribute more than were used, but some people chose not to use them when they were left for them. And so then, as well, the confirmatory testing, in a way, is easy because we have these lay counsellors who are out there in the community who are able to do the confirmatory testing. We also left calling cards with the CHIP's phone numbers on, so people did ring to say, please come and, I've got a result, help, whatever. So we did have that. In terms of linkage to care, as you saw, this study is only just recently finished. The last participants were enrolled at the end of April. And our experience in HPTN 071 is that linkage to care from the community does take a period of time. So we wanted to give them at least 3 months, and so we will be looking at our linkage data in the next few weeks. So we haven't got that yet, but we will be putting that out. Qualitative data, we have a lot of qualitative data, and I'm sorry I had to skip it very quickly because I only had 12 minutes. But we do have a wealth of data looking at the factors why people chose to self-test compared to doing the finger prick testing, and also how the lay counsellors felt that this affected their work and how the community felt having the lay counsellors affected self-testing. So there is an awful lot of the qualitative data that will come out, and maybe we can discuss a bit more later. And then the supervised testing. So again, this was a new initiative. So I think people hadn't really seen self-testing before. It was very novel. I think that most people, these chips, they've been looking after these same zones now. This is, their third year of looking after these. So they have a very good relationship with the individuals. And so I think most people asked them to stay because they weren't 100% sure. The chips weren't always there when they were actually testing. They could test in another room. But I think it was more for reassurance that if there was a problem, the chip could help or anything like that. And I think because it was new, more people, they had the chip there, so they could say, just hang on while I do this. But my feeling is that as confidence with self-testing increases and as this becomes more known about, then I think people won't need so much supervision. And most of our participants said, well, now I've done it, it's easy, I can do it now. But I do think that some of those individuals, it was just a replacement of the rapid test because it was new. And you could see that the yield from the supervised testing was very similar to the finger prick testing. So I think really that was more just replacement because it was new, whereas I think some of the other groups were people who we would not have reached, and we have not reached before using the finger prick testing. Was that all?
Great, thank you, Helen. I'm particularly impressed you can hold 4 questions in your head. Thanks very much. So I'd like just to make a couple of comments in closing, and then I'll ask Jason if he'd like to make some comments afterwards. We've seen this conference is, we've heard a lot about the excitement that UNAIDS has been making about treatment and about getting more than half the people who need treatment on treatment. People have missed the fact that it's very clearly stated in the reports and the press release from UNAIDS that we're very worried about prevention and about the fact that new infections are not falling as quickly as they should. We hear a lot about exciting things, implantable PrEP, long-acting PrEP. We're not going to have those for a long time. Even oral PrEP, we know, is expensive, and the impact at a population level has yet to be determined in many circumstances. So somebody at the start, perhaps it was you, Jason, said that we were talking about the good old forgotten things. And it's fantastic to have a range of 6 presentations, all with positive outcomes, about very straightforward interventions that actually we know a lot about them working. Keeping girls in school, helping to relieve poverty, thinking about HIV testing in new and exciting ways with partner notification and self-testing. The good news that male medical circumcision may have knock-on benefits for women too, beginning to come through, and that harm reduction for people who use drugs is vital. What's more, all these interventions, both systemic and behavioral, are extraordinarily good value compared to some of the other prevention interventions out there. So I'm delighted. You're probably the converted who came to this session. Nonetheless, please spread the message that there are many things to do apart from PrEP and implantables and treating people, and that they're crucially important to the future of this epidemic. And that's how I'd like to pass over to Jason for any things you want to add.
Actually, I have nothing to add to that. That's exactly what I was probably trying to say, not as eloquently at the very beginning, but I'm glad you reiterated it so nicely. And then we're actually out of time, so I wanted to thank everyone for showing up, and I would like to yield the remainder of my time to the two people in the room who had questions that I tried to pass to the end, and unfortunately we won't have time for those. But please, you could come up and ask Shona. I think they were for those questions in. So thank you very much, and enjoy the rest of the conference and your time in Paris.